discussion session. So the next speaker is Ahmed Eshmawi, who will be speaking about different surgical techniques for mitral annular calcification. Ahmed?
Thanks a lot, Michael. It's an honor for me to be here today as Dr. David. Thanks for the invitation. I have no disclosure, so I'm going to talk about surgical techniques to address MAC. Let's be, honest at the beginning. As we know, there is no consensus on what is the best way and the safest way to handle MAC. So we have a lot of different techniques. So we spent in the last 24 months almost trying to generate some consensus on what to do for MAC. Dr. David was one of the members of the writing committee of these documents that I would strongly encourage everyone to read. I presented this at the AATS in Seattle a few weeks ago, and it has 33 consensus recommendations on how to deal with MAC. As you see in this figure, we believe that the approach to MAC should be individualized, means you should decide about what to do based on the anatomic risk of MAC as well as the general patient risk. In other words, younger patient with less severe degree of MAC and good endomyocardial tissue quality, you better resect the MAC because that's the most curative way to deal with it. However, patient with more extensive degrees of MAC, poor endomyocardial tissue, multiple risk factors, this patient you absolutely need to be more conservative because of the risk. In general, that's our simplified approach to MAC. We CT scan everyone because we need to understand the extent of MAC before we go to the OR. Any patient who had a partial or posterior MAC or non-circumferential MAC, you can always deal with these patients in the OR by using standard surgical techniques, whether valve repair or replacement. Circumferential MAC, that's when we get interested in using one of these hybrid devices, as I'm going to show you a few videos showing that. This is an example of a patient. I'm going to talk about resection techniques first. You see the patient had a previous mitral repair, torrential multiple jets of MR. So when we explore that valve in the operating room, you can see the first surgeon have put a band and a feeder stitch. So as we start doing our re-repairs, as we have seen in multiple videos before, we take out the prosthetic valve so we can do a proper valve analysis. And then once you look underneath the posterior leaflet, you can see this part of MAC is not very thick, it's not extensive, it's actually limited to the annulus. So in these cases, you can easily dissect this MAC pore using sharp dissection. You can go from commissure to commissure within the fibrous capsule of the MAC. We then reconstruct the AV groove. There's different ways. You have seen multiple videos of patch reconstruction, as Dr. David commented earlier, that can calcify. In this case, we used another technique, which is a patch advancement atrioventriculoplasty. You create an atrial flap and you advance it into the ventricle using this figure of 8 matrix suture. This is a very good technique because it uses a viable tissue that's not going to calcify, and it averts the AV groove vessels, so you have less risk of AV groove or ischemic complications. This is a second row of suture line. You can repair or replace the valve. We augmented the valve, the posterior leaflet with a batch. And then we had good line of coaptation. We measured the anterior leaflet, and then we true-sized the valve. So again, the discussion is not particularly in this case about whether to repair or replace this valve, but about how to handle the MAC pore. This, again, the ink test showing decapitation, which correlates with a good echo result. What about respecting the MAC, as I showed you, which sometimes you have to do in high-risk patients? One of the techniques is an oversized annuloplasty. So sometimes when you do the repair, you can just limit all the leaflet work inside the leaflet without going to the MAC pore, and then just oversize the annuloplasty to accommodate for the calcium as well as for the leaflet tissue. Occasionally, you have to put the blade-jaded ring or band suture from the ventricle up to the atrium. This is, again, a very short video that showed the MAC in high-risk patients limited to the posterior annulus. The anterior annulus was spared, and the anterior commissure was also spared. So this is a repairable valve by any means. We put the annuloplasty sutures, and then you see the true size of the anterior leaflet is only 28. Here we oversize it because, again, the annuloplasty will go behind the MAC. You look at the ink and test it, very similar to the first case, deep, no residual leak. So that's, again, a safe way to handle MAC if you don't want to get into the grooves of the AV groove. Another patient, she was a 75 years old female patient. This patient came acutely sick in heart failure after episode of rapid atrial fibrillation, severe MR. This was her echo. You can see this mushroom-shaped coil flower MAC, and then this extensive subannular calcification. You can even appreciate that on echo. We did the CT scan as we routinely do in this patient. She has like what we call a partial or a horseshoe MAC, doesn't go to the commissural, doesn't go anteriorly. So this is, we know that we can do something about this valve safely in the operating room. So here you can see the MAC again infiltrating the ventricle and extended posteriorly. That will be very dangerous to take out. So what we did, we disinserted the anterior leaflet and then didn't sacrifice the anterior leaflet, flip it back to the posterior leaflet and suture it to the posterior leaflet, creating what we call the neo-annulus. Remember, now we're doing what we call total valve spare mitral valve replacement. Again, very well-seated device, no paravalvular leak, good result for otherwise could have been a very dangerous surgery. Another patient, 64 years old female. This patient had a TAVR. Unfortunately, after the TAVR, as you know, sometimes you push this curtain posteriorly. She developed mitral stenosis with significant symptoms. So we approached that valve in the OR through an inflow-outflow. So we took out the TAVR, opened the root into the dome of the left atrium. And I'm showing you these videos that sometimes you don't have to take all the calcium out. Here we're using a big SH needle behind the shoulder of the MAC port. You don't have to go too deep to avoid injuring the groove or the circumflex. But that way we were being able to put all the posterior valve sutures and then replace the mitral valve. I mean, on the way out, we reconstructed the groove, the dome of the left atrium and replaced the aortic valve. Again, a very, it's a complex surgery, but in experienced center, I mean, who have a lot of experience with these cases, you can get a good result. Very well-seated valve, wide open outflow, no paravalvular leak or rocking procedure. So again, a great result for otherwise a very sick patient. And that would particularly also be helpful if you have more of an anterior MAC because you get rid completely of the calcified curtain. This is another video that shows these periannular sutures. I just have to be clear. When you do this, you have to make sure you put an adequate sized valve because you can create a patient-prosthesis mismatch or subvalvular obstruction, which can be a trouble. So you have to make sure that if you leave the calcium, you put a properly sized prosthesis. What about hybrid devices? I'm going to show you quickly again an example of this patient. This patient was 85 years old. Calcific mitral stenosis, severe mixed disease. She had multiple comorbidities. HOCM really rejected from many other centers before she came to us. She presented in class 4 for the best 6 months, begging us to do something for her valve. This is the echo. You can see, you can appreciate even without looking at the CT scan, this is a circumferential MAC, right? It's mainly stenosis, anterior and posterior MAC. We do the CT analysis. Usually this patient gets screened in TMVR. A majority of them gets rejected because those are a small ventricle with narrow outflow. There is nothing you can do transcatheter to help them. You see this is a circumferential MAC. It spares only the anterior leaflet. Again, very deep extension into the ventricle. Bad case. You took the patient to the RD valve analysis, almost identical to the CT scan. Again, very circumferential thick. The anterior leaflet is spared. We closed the open commissure because that can be a site of paravalvular leak, and we resected the anterior leaflet to avoid LVOT obstruction, which we know the Achilles of this procedure. We wrap these valves in felt, and then we deploy them. We add some sutures if possible, and then you see the echo, very well-seated valve, no outflow obstruction, no MR. You wouldn't even tell if this was a SAPIEN valve if you don't know about it by looking at the echo. This was a patient. I do these cases with Gilbert, so we really have to partner with the structural heart interventions to do these cases. She lived many years. My last encounter with the family, that they were very appreciative. They had excellent quality of life before, unfortunately, she passed away of a stroke. So in conclusion, surgery for MAC should be individualized. So the surgeon has to be familiar with basically an armamentarium of surgical techniques that sometimes you have to be pushed to use one of them. CT imaging is key now. In 2025, no patient should go to the OR without CT and understanding the valve analysis, the MAC extension. Be flexible, use resection and run resection as indicated based on, again, the anatomic risk as well as the general risk, and if this patient can tolerate a complex surgery, and also the surgical expertise is key in deciding what to do. The hyper procedure should be a bailout. It should never be the default. We know how to do this hyper procedure, but we really use them because most of the time we actually get away by using one of the standard techniques. Finally, avoid futile interventions. A lot of these patients, they have multiple comorbidities. It doesn't matter what you do at the mitral valve level, they still die within a year or so. The 1 year mortality in the transcatheter ward was about 50% because of the extension of MAC, and we know that MAC is a generalized disease that can actually impact the patient's survival more. Thank you so much.
Thanks, Ahmed. And that was